Hello, everyone. It's a pleasure to be part of this meeting today, and thank you for the kind introduction. What I'm going to do is to review recent clinical data from trials using oral PrEP. I'm going to focus today on oral PrEP regimens, but as you can see on the slides, we have topical regimens and parenteral drugs that can be given also for pre-exposure prophylaxis and that look quite interesting. In terms of oral PrEP, we have two agents that have been approved, TDF-FTC and TAF-FTC, and one is being investigated as a new oral drug for PrEP, islatravir. And I'm going to review now some of the recent data supporting the use of these PrEP agents. But before I do that, let's look at the overall map of PrEP initiations by country at the first trimester of 2021. And as you can see on this map, there is a wide diversity across countries regarding PrEP implementation, with the highest number of people on PrEP in the US and in some countries in Eastern Africa and South Africa. And as you can see, the overall number is 1 million of people who have initiated PrEP right now. And this is quite far from the 3 million of people who should have accessed PrEP according to the UN commitment in 2016. So there is still a long way to go to implement PrEP in different countries in the world. I'd like also to say a few words about the impact of the COVID-19 pandemic on PrEP initiation worldwide, and I would like to focus first on France. And these are data on PrEP initiation in France from January of 2016, when PrEP was first approved in France, up to June of 2020. And overall, 32,000 people have initiated PrEP since 2016 in France. And you can see on this graph the number of people who have initiated PrEP per month between 2016 and 2020. And you can see that overall there was a nice increase from less than 200 people per month to more than 1,400 people per month just before the pandemic. And as you can see on this graph, during the first wave of the pandemic in France, there was an 80% drop of PrEP initiation, and we are just trying to catch this rate of PrEP initiation right now. But clearly the COVID pandemic has had a major impact on PrEP initiation worldwide. I'd like now to review some of the most recent data on oral PrEP, and I'll start with this study. The Discover study has been published in the Lancet last year. This was a randomized, double-blind, placebo-controlled study conducted among high-risk MSM and transgender women. We were randomized to receive either a daily pill of FTAF or a daily pill of tenofovir FTC. The study duration was 96 weeks, after which an open label extension was proposed to the participants. The eligibility criteria were participants who had at least 2 episodes of condomless anal sex in the past 12 weeks or rectal STIs in the past 6 months. They had to have a normal eGFR above 60, and prior use of PrEP was allowed in this study, which was conducted mostly in Europe and North America. Visits were conducted every 3 months. And when you look at the baseline demographics of the participants in that study, you could see that their participants were mostly white MSM. Very few transgender women were enrolled, less than 2%. And most participants were white male, so very few Black in particular, with the median age of 34 years. Of interest also, very few were already on PrEP at baseline, between 16 and 17%. This slide shows you the primary endpoint of the study, the HIV incidents, and the study was designed to show the non-inferiority of FTAF in terms versus TDF-FTC. And as you can see on the right-hand side, when you look at the incidence rate ratio of HIV incidents, you can see that the point estimates favored FTAF. But when you look at the confidence interval, it crosses 1, so there was no superiority. But still, the confidence interval was below the non-inferiority margin of 1.6. So clearly, these data show that FTAF was non-inferior to TDF-FTC. Not superior, but non-inferior. And when you look at the number of infections, you can see that the numbers are quite similar, especially if you take into account that in the TDF-FTC arm, 4 individuals were already infected at baseline. Interestingly, the authors also looked at the correlation between adherence to the drug regimen and HIV diagnosis. And in this case-controlled study, you could look at the median tenofovir diphosphate concentration in dry blood spot in both individuals who who acquired HIV in the FTAF arm and 35 negative controls. And what you can see here is that those who had HIV infection diagnosed had much lower tenofovir diphosphate level, which were consistent with an adherence of less than 2 doses per week. And the same was true in the TDF-FTC arm, where in this case-controlled study, the tenofovir diphosphate concentration in dry blood spot was also much lower in the people who acquired HIV infection as compared to the HIV negative control. So these data suggest, as we already know, that PrEP is really effective, especially when you take PrEP. And in people with low adherence to PrEP, there you have a high risk of HIV acquisition. The other interest of the study was to compare the safety of the two PrEP regimen, FTAF to FTDF. And what you can see on this slide was an overall very good tolerability of the two drug regimen with a limited number of serious adverse events. Only 21 to 24% of the individuals developed study drug-related adverse events. And in terms of adverse events who led to discontinuations, you can see that only 1 to 2% of the adverse events reported during the study led to study drug discontinuation. So clearly, both regimens were equally well tolerated. And then you're looking for differences between the two regimens. And so that's why the authors looked at bone mineral density between the two study arms. And there you can see a significant difference in a subgroup of people who had bone mineral density both at baseline, week 48, week 96. And what you can see is at week 96, a significant difference, both at the spine and hip level, favoring FTAF. But it's important to highlight that these statistical difference may not be clinically relevant because the difference remains quite small, especially in young individuals. The same was true for renal biomarkers. If you look at the left-hand side at the eGFR change from baseline, you could see that, again, in green, the change was actually more limited with FTAF as compared to FTDF. But even with FTDF, the decline in eGFR after 2 years was only of 4 ml per minute, so a very small difference. So although these are statistically significant differences in these renal biomarkers, the clinical relevance is small. And if you look at the individuals who discontinue the study because of renal adverse events, and remember that the study was double-blinded, only 2 individuals in the FTAF arm and 6 in the TDF-FTC arm discontinue because of renal adverse events. And overall, only a single individual out of more than 2,500 randomized to TDF-FTC developed the Fanconi syndrome. And that's why, actually, when you look at the IS USA Guideline Panel, which makes guidelines for treatment and prevention, and these are the recent data from 2020, these guidelines highlight the fact that FDA approved FTAF, but only for MSM, excluding those who have receptive vaginal intercourse and requiring requesting additional studies that are ongoing right now in women in South Africa. FTAF should be used as a daily pill, and we have no data supporting the use of event-driven PrEP with TAF-FTC at this point. And what's more important is that the improved safety profile regarding or compared to TDF-FTC has not been demonstrated clinically so far. And the clinical correlates of the bone mineral density data and renal biomarkers data remain unclear. And it's only when the eGFR is below 60 ml per minute where you cannot use TDF-FTC, that TAF-FTC is recommended, or in people who have a prior history of osteopenia or osteoporosis. And the reason for that is mainly around cost, because whereas TDF-FTC is available as a generic drug, so the cost is very low, TAF-FTC is not. In the future, when both drugs will be at the same price, maybe things will change. And at CROI this year, Hoover and colleagues reported the use of TAF-FTC for PrEP in the US. And in the US, where the issue of cost is not as critical as it is in Asia, Africa, or Europe, you could see that the number of PrEP users using TAF-FTC increased quite dramatically from 2,000 people to 76,000 people within a year. So we may expect such an increased use of TAF-FTC in the future when the price will be the same as a generic. Let's switch now to data with sex-driven or OnDemand Prep. And you remember that these data come from the ENRS Hypergate study showing in a double-blind study that OnDemand Prep was 86% effective as compared to placebo, and this relative reduction in HIV incidence was even higher, 97% during the open-label extension. But this use of OnDemand Prep was limited to this study with a limited number of participants, only 400 participants. And so we wanted to provide additional data on the efficacy and safety of OnDemand Prep. And why studying OnDemand Prep? Because the dosing regimen could be quite convenient for people who are not willing to be committed to a daily PrEP regimen, and that might improve their adherence to PrEP and PrEP effectiveness. It gives also a clear guidance on how to start and stop PrEP. You may expect a better safety due to lower drug exposure, improved cost effectiveness, and potentially even an easier diagnosis of breakthrough HIV infection and a lower risk of selecting drug resistance. These are not yet demonstrated. So at CROI this year, we presented the 3-year follow-up of this open-label prospective cohort study in the Paris region, enrolling HIV-negative high-risk adults to be followed in this prospective cohort. And the individual could choose between a daily TDF-FTC or on-demand TDF-FTC. They could switch from one regimen to the other during follow-up. And the idea was to show after 3 years a 50% reduction in new HIV diagnoses among MSM in the Paris region. Unfortunately, we couldn't provide these data because of the COVID pandemic. We didn't have reliable data on new HIV diagnoses in France in 2020. So we presented data on the baseline characteristic of these individuals, who were quite young individuals in their 35, 36 years of age. Most of them were MSM. Half of them had a history of PrEP use. And in terms of sexual partners in the prior 3 months, those opting for on-demand PrEP had fewer sexual partners. In terms of adherence to PrEP, as shown in this slide, you're looking at tenofovir diphosphate level in dry blood spot or pill counts. You could see that overall, in the on-demand arm, the use of pills was about 2 pills per week and 7 pills per week in those opting for daily PrEP. And these data are consistent with the drug levels in dry blood spots. Importantly, we wanted to look at HIV incidents in this cohort with a mean follow-up of 21 months and a rate of discontinuation which was quite low, maybe because of the poor counseling and adherence counseling that was provided to the participants. And during the 3 years follow-up, we had a global HIV incidence which was quite low, of only 1.1 per 1,000 person-years of follow-up, with only 6 cases of breakthrough HIV infections. All 6 cases were people who actually discontinue PrEP. And when you look at the HIV incidence per arm or per group, you could see that the incidence was similar, 1.2 per 1,000 patients years of follow-up, because we had 3 cases of breakthrough HIV infection with either daily or on-demand PrEP. In terms of adverse events, we reported a little bit more adverse events in the individuals who opted for on-demand PrEP, mostly because of an increase in gastrointestinal adverse events. But if you look at the rate of treatment discontinuation due to drug-related adverse events, you can see that the rate was very low, 0.3 per 100 person-years. And only 3 individuals have permanent PrEP discontinuation because of gastrointestinal adverse events. So there were a few limitations with these data. First, this was not a randomized trial, so it could be difficult to compare the 2 regimens. We had more frequent drug-related gastrointestinal adverse events with on-demand PrEP, no data yet in heterosexual and women, and no data with TAF-FTC. And so we're trying to see whether we can even simplify this 2-1-1 dosing regimen. The last drug I'd like to spend a few minutes on is islatravir. This is a new antiretroviral agent, nucleoside reverse transcriptase translocation inhibitor that is being developed for both treatment and prevention. It has a potent antiviral activity with low in vitro IC50, with activity against NITR resistance viral strains. As you can see on the left-hand side panel on the top, there is nice decline in viral load with a single dose. And this decline in viral load, which can achieve less than around 1.5 log decline, has been correlated to PK result in PBMCs, and a threshold of 0.05 picomole per 10 to the 6th cells of islatravir triphosphate is associated with a decline in viral load of at least 1 log. What's interesting with this drug is also that it has a very long half-life of more than 120 hours in healthy adults, and that the drug also concentrates at high concentration in rectal and vaginal tissue. So it makes the drug quite a nice regimen for PrEP. And in a macaque model, Markowitz and colleagues were able to show and report a protection with this drug used for PrEP in the Shiv rectal challenge macaque model. At FOP earlier this year, Sharon Hillier and colleagues reported the blinded interim analysis of a randomized study of islatravir versus placebo conducted among HIV seronegative adults at low risk of HIV acquisition and who were given a single pill of islatravir once monthly, either 60 milligram or 120 milligram. This was a 24-week study, after which the patients were followed for an additional 12 weeks. And what was interesting was to look at the safety of these drugs given once monthly. Very few adverse events, only 7% of people complain of headaches, diarrhea, nausea, or abdominal pain. And remember that these are the pooled data, so we don't know how many of these individuals were receiving placebo or islatravir. Only 2 individuals discontinued the study drug because of adverse events, sensation of foreign body in the throat, or rash and itching. No serious adverse events or death, so quite promising in terms of safety. What about PK? What you can see on these graphs are the mean islatravir triphosphate concentration in PBMCs, the blue dots, and these were overlaid on population PK models simulating the median islatravir triphosphate concentration in PBMCs. And what you can see in the left-hand side panel in blue are the modeling of the PK, which remain above the PK threshold of 0.05 picomole, which I was referring to earlier, and suggesting that with 60 milligram once monthly, you remain above this threshold and you would probably be expected to be protected against HIV acquisition. And when people take the last pills at week 20, you could see that even beyond week 24, for the next 4 weeks at least, you will stay above this PK threshold. And the same was true with the 120 milligram given monthly. So these are, again, very encouraging data, and similar data were obtained also. We have high levels of islatravir triphosphate in rectal, cervical, and vaginal tissues. And so these data were good enough to allow Merck, which is developing these drugs, to launch 2 large phase 3 studies for PrEP with the monthly pill of islatravir in 4,500 women, in an adolescent girl in sub-Saharan Africa, and a similar study in 1,500 men and transgender women, comparing islatravir given 1 monthly to the approved PrEP regimen. With that, I'll stop, and I'll thank you for your attention and be ready to answer any questions. Thank you.